Hello, and welcome to the very first episode of Think Big and Loud with LSVT Global. My name is Beth Peterson, and I will be your host for today's episode. We are so excited to get our podcast up and running. It's been an idea we've had for a while now, and we decided that April would be the perfect time to launch. That's for a couple reasons. First is that April is Parkinson's Awareness Month. And as part of that, we want to make sure that we are spreading awareness about Parkinson's and then also supporting those with Parkinson's and their family members and kind of care network there. The second part of why April is so exciting for this launch is that it's also, at least in the US, National Occupational Therapy Month, which gives us a chance to recognize all the amazing work that our occupational therapists and occupational therapy assistants are doing. So we thought, let's go ahead and launch in April, and so that we can recognize both of these important topics for the month. And with that, I'm very excited to have a couple of my occupational therapy colleagues joining us as guests today. And I have Erica Vitek and Julia Wood. And I'm going to go ahead and let you guys introduce yourselves. So Erica, why don't you go ahead and start? Just tell us a little bit about your background, what your degree is in, where you work and live. And I'd love to hear why you got into occupational therapy.
All right. Thanks, Beth. Super excited to be here. Happy Occupational Therapy Month. And I am just to tell you a little bit about myself is that I have been an occupational therapist now for 22 years. I went to school at Concordia University, Wisconsin, and right out of school, I started working for Aurora Healthcare, which is where I still work to this day. And so I've been there for 22 years, and I live in Wisconsin. I live just south of the city of Milwaukee, so more rural I live, and then I head into the city to work, and my area of practice being mostly in working with people with movement disorders, specifically Parkinson disease, as well as pelvic health related conditions. So I work with bladder and bowel conditions, and I have a specific passion for helping individuals with Parkinson's with those problems as well. And really what brought me to occupational therapy was initially physical therapy. I was touring schools to potentially go into the field of physical therapy. And at Concordia University, Wisconsin, the occupational therapy program director came to me and was like, "You don't want to go into physical therapy, you want to go to occupational therapy," on my tour. And she brought me in for a little talk about what occupational therapy was. And I was like, oh my gosh, occupational therapy sounds amazing. And I just connected with it even more than I connected with physical therapy, or what I thought I was connected to in physical therapy, and went for it. So then that's where I ended up, and just love what I do now and can't wait to share more about how I help people with Parkinson's.
Awesome. Thanks, Erica. I can completely see how those paths align, because I just feel like passion exudes for you in this area. So that's really neat that you found it right away. You knew that's what you wanted when you're introduced to it. So I can tell you're on the right path. All right. And Julia, if you don't mind sharing a little bit about yourself as well, and also why you got into occupational therapy.
Absolutely. Thanks so much for having me, Beth, and welcome to all the OTs out there, and happy Occupational Therapy Month. So my story is a little through the back door with how I got into OT. So occupational therapy is actually a second career for me. My undergraduate degree was in exercise science and wellness, and so I had a very successful movement studio out in the Seattle, Washington area, where I mostly did Pilates and gyrotonics, so kind of specialized biomechanical training. So similar to Erica, I thought when I was going to go back to graduate school that I would do physical therapy. And I had some physical therapists in my studio at the time that worked. And one of them said to me, she's like, "But you think like an OT." And I asked why she thought this. And I was notorious for, I would go to my clients' work. I'd go to their home. I'd go wherever they were so that I could see what they were doing in real time and really see what was going on as far as their biomechanical issues. And so OT was born. And then as far as with Parkinson's, what's really fascinating with that was I just fell in love. I had a rotation at the Mayo Clinic and inpatient rehab. For my clinicals, and I just fell in love with my patients with Parkinson's, and that's what I wanted to do. And ironically, I was told in my field work that there wasn't really a role for OT in Parkinson's. It was really just speech and PT. And I remember thinking, I'm going to change that. So I was looking for jobs in kind of the Northeast corridor because one of my children was getting ready to go to undergraduate school at the University of Delaware. And I really wanted a job working in Parkinson's. And it was like my first OT job, really out of the starting gate. And I wasn't finding anything. And so long story short, I applied for what I thought was an inpatient rehab job at Pennsylvania Hospital. And I got this email that was like, there was an error. It's actually not an inpatient rehab. It's in Parkinson's. And it's one of those where you're, kind of trying to clear your eyes. And I'm getting my husband going, at this point, am I just imagining that it says this? And so I interviewed a couple of days later and had the job and have been in Parkinson's ever since. And so unfortunately, with the pandemic, I do have a child with special needs. And so I transitioned to from being at a center of excellence at the University of Pennsylvania to working for the Lewy Body Dementia Association as the director of professional and community education. And so I still do a lot of community engagement work and some independent consulting with Penn and in the Philadelphia area where I still live. But then I have more of a national presence now with education for both people in the community, people with Lewy body dementia, their care partners and families, but then also healthcare providers. So it's really great to continue to be involved in LSVT. And I've really been pulling that into our world over at LBDA and getting our community set up. And we've just been hearing great stories. So excited to be here. That's my long story.
Oh, I love it. And I knew you did a lot, and it's really neat to actually hear everything that you do. It's very impressive. And I think my favorite part of what you just said was, there was a lack of occupational therapy or seeming to need it with Parkinson's. And you said, I'm going to change that. And I think you definitely have. So that's really cool. And so kind of tied into what you've been saying, Julia, if you don't mind, for those in the audience who might not be as familiar with occupational therapy, I know sometimes there's confusion with, OT and PT or exercise medicine. Can you just tell the audience kind of more specifically what occupational therapy is and why it might be needed for certain people?
Absolutely. Well, part of why I had the suspicion that there was a role for OT in Parkinson's is I think there's a role for OT in everything. So with occupational therapy, our role is really to help people knock down any barriers that are getting in the way to participation. So ultimately, we want to know what you would like to do, what you're passionate about, what you need to do in a day, but what also, brings you joy, and then how to help you maintain that. And so I feel like a lot of what we do is really help people maintain their purpose, maintain their connection. I think sometimes it gets whitewashed a little bit into just activities of daily living, and that's definitely things that we can address. But I think it's much bigger than that. I think it's really helping people navigate their independence within the construct of what's meaningful in their life. And then we're going to work as a team with PT and speech and even with other healthcare providers to make sure that we're supporting that individual in being able to do whatever they want and need to do in their daily life. So I think I love that our roots are in mental health and in the whole arts and crafts movement, because I do think I had a professor once early on who said, if you're working with human beings, everything is mental health. And I think we've really seen that post-pandemic. And for me as an OT, I think that underlies every patient that I look at is what really motivates them. What are they passionate about? What do they enjoy? What's meaningful to them? And then now, how do I really personalize the care to where I'm going to center it onto what they need and want to do? And so I personally think we all need OT. In fact, a lot of times I feel like I need an OT. I think there's something in it for everyone because it's so person-centered and holistic.
That's great. So again, I can really tell you're in the right profession here. All right, Erica, I'm going to have you take this next question, and I'd love to just hear about what led you to get deeper into the LSVT big world? And then what aspects of this approach do you find most rewarding?
Julia, thank you so much for telling your story again. I know that we know each other and I've heard it before, but it's just so awesome. And the way you describe OT, I just find just awesome because it's everything that we are about. So you described it so beautifully. So yeah, so interestingly enough, unlike Julia, who knew she wanted to treat people with Parkinson's, I had no idea what fun was in store for me in regards to treating people with Parkinson's, because honestly, it is just such a rewarding area to practice, because these individuals have potential they have no idea that they have. And it's an incredible area to practice. So how I even ended up even thinking about LSVT was because when I got my job with Aurora Healthcare, I was very passionate about pelvic health. I was like, I want to be a pelvic health OT. And when I got to Aurora Sinai Hospital, which is where I work, the drive in me was to work in pelvic health, and they didn't really have a place for me in pelvic health at the time. The job was acute care. I was like, all right, I'll try out acute care. It was kind of the job market at the time. I didn't really have a lot of choices. And we happened to be a center of excellence for Parkinson's. And I was like, yeah, I'm going to have to learn a lot about Parkinson's right now, because the physicians I worked with at the time, super passionate, 2 movement disorder specialists that had their private practice run right out of our big hospital system. They were of the mindset at the time, this was 22 years ago, that they did medication holidays, where they would take away the medications and admit their patients to the hospital for acute care stays and restart their medications to get them on the right path with their carbidopa, levodopa mainly, or other things like if they were having delusions or hallucinations or other types of symptoms. They would just wipe it clean and start fresh in a safe environment where they could get therapy. And then a lot of times they'd go to inpatient rehab. But on the acute side, I was working on the unit where they were all, initially getting admitted, and they were just taking off all their medications. So it was an experience. It really was. I had to really get to understand what these on and off times. I just had no idea what are on and off times. What is this medication? I was a new grad. It was all brand new to me. And people couldn't move. They were off their medications. It was really very interesting. And then as they were coming back on, I really had this potential in rehab that I was like, wow, I can really facilitate their movements, their occupation, their ability to, and obviously in acute care, our focus is a little more on ADLs because we're trying to get them on to the next step for, taking care of themselves and getting home and things like that. But just an incredible experience for me. And I basically, my whole caseload, you'd have 8 to 10 patients on your schedule for the day. And all I saw was people with Parkinson's. And so it was just an amazing experience. Well, over the years, I was like, there's got to be more to this rehab. I didn't want to only see people for 4 to 5 days while they were doing this and then go to inpatient rehab, and I never saw them again. I saw that there was potential beyond that and wanted to figure out, well, how can we help these individuals more? And I learned about LSVT big through kind of the grapevine. I don't exactly remember who told me about it, but I was always looking for courses, and I believe I just kind of came upon it, and it was going to be in the Chicago area, drivable for me, and went down there and took it. And I was like, this is going to change people's lives. I was so impressed with the technique, and I knew that it was going to work because I had years already of experience treating these people. And I just knew it was going to work. So came back, my physicians they were on the train of rehab, but I had to really present it in a way like, all right, here's a calendar. This is what it's going to look like. 4 times a week for 4 weeks. You're going to refer them to me. I'm going to treat them an outpatient. And I got my supervisor to agree I could try some outpatient. I was already dabbling in the pelvic health by that time, 2009. And so I'd been there for 7 years, started to do some outpatient. They're like, it'll be a better transition. You're already doing some outpatient. Got started, and it's been nonstop ever since. 15 years of using LSVT big. And I've had 2 people every month treating them. I've treated over 350 4 times a week individuals and utilizing LSVT big. And it's just been outstanding. And just what I really love about it is kind of just reiterating what I was saying. The the movement capabilities, the ability of these individuals to just take it, run with it. And they're like, oh my gosh, I had no idea I could still move my body like this. I had no idea I could still even do these tasks. In fact, right now I have a gal who she is living now in like kind of more of an independent living. She moved from her apartment, but she still has a lot of independence. She still drives and things like that. And she came to her session today after we'd been working. She has apraxia on her right hand pretty bad. It's really tough for her to write and to use her hand to open her medication bottles and things like that. But she told me at the beginning, she's like, I can't even tie a garbage bag. So we're in our third week. We're still working. We're practicing with like the disposable bags that you could take to the grocery store with the handles. And we're practicing with real world things in the clinic. And she came today and she was like, I tied my garbage bag last night. And she was like, I was in my apartment by myself and I was cheering. My arms were up in the air and I was like, I tied the garbage bag. Yay, yay. And she's like, yes, yes. And it was just like, it's amazing to get excited about something that you think just is an everyday kind of thing, that you should just be able to grab the garbage bag and tie it. And she couldn't do that. And when she could, it was just like this outstanding experience and so exciting. We hugged and high-fived and got to exercising. So pretty exciting.
Oh, that's so great. That's a wonderful story. And I know, when you work with these people 4 days a week for 4 weeks, you do really get to know them. And it's so neat to share in those joys with them. I love that. Just picturing her cheering herself on. That's so great. And you've really empowered her to know she could do it. And just having that celebration is really cool. Another thing you said I really liked, we get questions from clinicians a lot. I guess, so I'm a speech language pathologist for those in the audience. So I work on the LSVT loud side. So some questions overlap a little bit, and we get questions from therapists who say, my center's never done 4 days a week, or we can't see patients for an hour. And I love how you took the course and you said, okay, here's what we need to do and here's how we're going to do it. And, it's really cool to say, yeah, you can bring it here and this is how you can do it. A lot of times, supervisors or those you're working with might just need some education on why. And if you present them the why and how it can be done, it can be life-changing for so many people. So it's also awesome to hear that success story and how you just went right in and did it. So that's great. All right. And Julia, Julia, I would love to hear from you about any, kind of success stories or what you find rewarding with treating your clients with LSVT Big.
Absolutely. I love that story with the garbage bag because, I think a lot of times too, when I was thinking back to my comments about what's meaningful, we tend to think of meaning and purpose as being these overarching things like world peace but I mean, when you need to tie a garbage bag, that is meaningful. And what's so great too is what I've seen and what I loved with LSVT Big when I do it is seeing how that one thing, like I remember we had a gentleman that really wanted to be able to cut his own steak and he was able to do it really quickly. And he had a hard time picking some of the functional component tasks, but once he cut that steak, he came in with a list of things he wanted to work on. It's like, once they see what it does, they're in. So I think that one of my favorites that we were talking about before we started recording is, this weekend there was an art show in our area of people with Parkinson's. And there was this woman a couple of years before the pandemic. So we think back now, that was like 6 years ago, right? It's hard to even imagine. But I did LSVT Big that long ago with her. And I remember she wanted to work on embroidery. And so that was one of her functional components. And she even told me, she's like, I think I might just give it up. I just don't think it's going to work. I've got some tremor. Like I just probably should just, do something different. And I was like, well, let's try it. And so some things we did were positioning, but then also some of it was really that amplitude in those fine motor tasks when she was doing embroidery. And it shocked me to no end when there was this giant piece. It was probably like 8 foot by 10 foot of embroidery that this woman had worked on for the past 6 years since I saw her. There was like an abstract piece of art and she had been doing this the whole time. And then she also was able to talk about how she's learned now that when she has trouble doing something, it's like, how can I do it bigger? How can I drive amplitude into it? And that's that ultimate carryover. I think when people really start to see, just like Erica said, that I didn't know I could move this way. I didn't know moving this way would make a difference. And they feel that for so many of them, it just really spreads into other things that they want to do. But but I just love that it sticks with people that long. I think especially if you get people early on, and not saying it has to be like right when they're diagnosed, that's great, but then they really see the benefit of it. And it's something they want to continue and carry on with. So I just seen the impact in many of my clients over the years as they continue to do that, of them being able to stay engaged with things that they love, not withdrawing from family members, staying social, all of the things that we've really learned, drive brain health in a lot of ways. We know now that socialization is so important. That's one hard lesson we got from the pandemic, that working on depression, anxiety, those mental health issues, we know all of this. There's even a lot of evidence around purpose and, ultimately your brain health. So I think that LSVT is just the perfect vehicle to set people up for success in whatever they want to do.
Yeah, that's great. I love that idea of spreading into other areas. Like you have them focus on something in therapy, and then that just like light bulb goes off. Oh, if I'm big in this, I can do this and this and this. And that's so cool. What a neat like chain reaction that you get from that. And so I love talking about the success stories and, all these great benefits, but I think it's also important to kind of understand if there's been challenges and how you guys might have overcome those. So, Erica, do you have any examples of challenges you've had when implementing LSVT Big and how you've worked to overcome them?
I think one of the biggest challenges as of late that I had in about the last 2 years was our healthcare system, being as large as it is, decided that we were going to have 45-minute treatment sessions. And I was like, no, that can't happen. We need hour sessions. This is very important. I've already been doing the program for all these years. I'm on year 15 now, utilizing it. And so I really had to go to bat for specialty clinicians. We're specially trained. We have years of treatment experience. We need a little bit more time with our patients who are typically a little bit more complex. So not just neuro patients, but my pelvic health patients. And so I went to bat for that along with some other experienced clinicians. But I feel like I was a big driver in the LSVT Big realm of driving that change. And we were able to get those hour sessions. And I do feel like a lot of clinicians do feel kind of trapped in this larger healthcare environment right now that is putting them in this situation where they're being forced to utilize treatment sessions that are dictated by their employer. And so I feel like having the evidence of all the experience that I had did help drive that. And I do also think the physicians that I work with help to drive the importance of that because they see the benefits. So I do have a great team that I work with that is also really pro therapy and pro LSVT Big. So that definitely helps. But that would probably be one of my most recent barriers, if we want to call it that. But I do also sometimes think patients sometimes have a fear of the intensity that it presents when you first tell them about what it's going to be like. Or they may say, I already did LSVT Big. And when you kind of dig in, they're like, oh, somebody gave me a 2 times a week and this and that, and it didn't really work. Well, that really isn't LSVT Big. So really taking it upon ourselves to educate patients that, you didn't actually, receive the full intensity program. You definitely, got to try it out. And it sounds like it did make a little bit of change here and there, but I can provide you with this 4 times a week as per protocol. And yes, it is intensive, but I feel like you are going to get into it and really, really notice the change. And I like patients to really get started with me so I can show them and let me show you what this can do for you. And we can really give them those aha moments like we've been already talking about. Like patients can really take it and run with it beyond what we do just in the session. So I feel like even in the first week, patients are just like, oh my gosh, I cannot believe how much this is changing my life. Or maybe they've only had traditional therapies and it's like, wow, I had no idea doing something at this intensive level my body could even handle it, or I could even do this. So those things really, we can bring a light for sure with the intensity level and why they need to really try it at that intensive level and how they can really use their body much differently. And sometimes transportation or other like social factors get in the way too, but helping people find a team I have a recreation therapist that I work with that is really, I mean, that is a real asset because she can help with transportation issues, with helping with finding like community support and things. So I'm really blessed to have that because we're obviously busy clinicians and it's hard sometimes to do that. But having that or social work on your team can be really, really great. And I know that Julia is really great with interdisciplinary teamwork. She does a lot of teaching in that area. So I know that Julia is all for interdisciplinary team too.
Awesome. Well, thanks, Erica. I think that's everything you've said is so important, and we see it again on the LSVT Loud side too. And sometimes with that intensity, just letting our clients know, yeah, well, it's 16 hours. It seems like a lot in a month, but if you think about how it's going to impact the rest of your life, it's really a short amount of time if you think of kind of that big picture idea. So it's really neat. I love that idea of you just need to jump in and try this. Let me show you what you can do. So I think that's great. And I'd love to segue over to what you were just talking about with Julia. Julia, I know you have a lot of passion and experience for that interdisciplinary, working together with your colleagues and also this holistic approach to treating your clients. So I'd love to just hear a little bit about your ideas with that. With both the holistic approach and then interdisciplinary care. So if you want to just go ahead and talk a little bit about those areas.
Absolutely. And I think Erica did such a great job of explaining all the different ways. It truly takes a village, from transportation to, medication management. There's so many, if you look at the symptoms of Parkinson's disease, and, a lot of times we see that iceberg, and the motor symptoms are just the tip of the iceberg. And then there's all of those non-motor symptoms underneath the surface. To me, that's where the team is so, so, so important. It's such a multi-dimensional, condition, and it impacts not only the person with Parkinson's, but also the care partner and ultimately the family. And so for me, I became very passionate about interdisciplinary care. I'm working with my colleagues at Penn. So we had a great physical therapist, great speech language pathologist. Also, we had social workers that were on a grant to where they could see and counsel not only our patients with Parkinson's, but their care partners and even family members for free. We had great movement disorder specialists, an incredible psychiatrist, and our nurses were phenomenal. And you just really saw how we all had to work together to make sure that we were covering not only, the different physical aspects of the condition, but also, mental health. A lot of times those issues came up, a lot of anxiety, a lot of depression, and, we really had to lean on each other. And patients are going to have a different rapport with everyone. You probably, if you have a healthcare provider, you might have certain doctors you like more, maybe you like your dentist, and you're more chatty. And I think that that's something that when you're on a really good team, it's recognizing that we each kind of play a piece of the puzzle. Sometimes what somebody might tell me, they didn't tell PT or vice versa. And so we all really work together. And I think that holistic approach too is really looking beyond just the physical manifestation of how someone's walking or if they can do their ADLs. It's really looking at their satisfaction in life, their quality of life, their mental health, how they see their role. I mean, I think so much of what Parkinson's does to people too is really impact that identity of who they see themselves as. And so I think that it's just really, you have to get to know that person and really think of them as a whole being, not just a manifestation of, symptoms. And with that too, when you work that way, it really helped us sometimes involve spirituality in care, which was something I loved. I used a lot of mindfulness-based stress reduction practices. Even I used mindfulness a lot of times as an attention strategy, because often anxiety and those issues with cognition and attention go hand in hand, because what we see so much with the non-motor symptoms is that they interplay with each other. And then they also interplay and exacerbate the motor symptoms. So, I had patients sometimes that, let's say they're having, a lot of freezing of gait, right? And we're working on all the strategies, we're working on the cueing and the rhythmic auditory stimuli and all of that. But really you start to notice what's underneath it is when their anxiety gets triggered. So then it's, what do we do about that? Is it referring out? Is it getting in with counseling? Is it working on maybe making sure that they have some cognitive behavioral strategies in place? So that was something that I dabbled in and got some training into. And a lot of OTs can have cognitive behavioral therapy training, so that you're looking at the different aspects of someone's person and how that's impacting and interacting with their disease. So that's the part I love so much about treating this condition, is really treating the whole person, not just Parkinson's. So thank you for giving me that soapbox moment.
No, I love it. No, as you're saying all this, I just keep thinking about how lucky your clients are to have you, helping them. Yes, you're an occupational therapist and you're going in with the goal to, help them with their movement, but that's not all you're thinking about. You're thinking about a lot of other things with the whole person. And it's so neat to hear you describe that. And again, that passion you have for that, and you can tell that spills over into your clients. So thank you for sharing that with us.
Thank you. I think I staffed the entire Parkinsoners choir practically in Philadelphia, because I was sending everyone, because you could really see, from a voice perspective, right? But also the mood, the socialization, them connecting with each other. I did a book club at one point. I mean, I love all of that stuff so much, which, to Erica's point about kind of the healthcare systems don't love that stuff so much. So that was a barrier and a challenge that I definitely think we all run into in trying to provide that type of care.
Yeah, well, and being their advocate. So I think that's really neat. Something else that you're doing by doing all these things with your clients. So that's really neat to hear about. All right, Eric, I'm going to switch gears a little bit. I know you recently did a presentation on LSVT big in pediatrics, and from what I've heard, it was very well attended, and it was a great presentation. So I'd love to hear more about, what research is going on with pediatrics and LSVT big, and anything that you're particularly finding exciting or interesting in taking LSVT big in that direction.
Yes, Beth, super exciting. At AOTA was a huge group of interested therapists in how do we apply LSVT big just to other even neurologic diagnoses. So we did talk about other neurodegenerative conditions in adults, but also in the neurodevelopmental kind of deficits that pediatric clients might experience. So really what I find so intriguing about LSVT big and peds is how it even got developed for Parkinson's, where LSVT big came from in regards to that. So starting with this really groundbreaking research in LSVT loud is exactly how it's starting out for LSVT big and peds. LSVT loud is breaking ground, amazing ground on utilizing LSVT big, loud concepts with kids with cerebral palsy, Down syndrome, maybe even autism or other neurodevelopmental diagnoses, and taking that now and expanding this idea to, if we can do it for voice, why can't we do it for movement? Why can't the limb motor system benefit from the same kind of drive and neuroplasticity-based principles that we utilize in LSVT big for people with Parkinson's or other neurodegenerative conditions? Why can't we apply that to neurodevelopmental conditions? So I have had the amazing opportunity of helping a little girl with a progressive ataxia in my clinic, and we did the program together, and it was amazing. Her mom was so happy, her family, so happy to see progress in something that's progressive and challenging, and to be able to see her make some change after having gone through years of traditional type therapies. So I think that's what really intrigues me almost the most about this whole thing, and these other therapists that were super excited about this as well, is that you have years of going through other therapies, maybe other intensive programs, but mostly, traditional type frequencies and intensities of therapy. And this is something new and different, and we can make a change in progressive ataxia. That's amazing. Like, we can make a change in control of movement, utilizing amplitude, utilizing controlled, firm starts and stops, and using those neuroplasticity principles of using salient tasks. So occupation, that's important to that person to really drive their ability to utilize amplitude and control deliberate movements in their day-to-day functional tasks that we practice during LSVT Big, and then take that with them to utilize in their everyday. It's really an amazing thing. So I do have the opportunity coming up. My employer is being very supportive of moving this into the peds world. So I'm really hoping to keep that going. And I do have someone scheduled with me this summer to try it with an individual that has Down syndrome and has not gone through a program like this before. So I'm excited to see the progress that we can make. And what's interesting though, is I'm really an adult trained therapist. So I have to kind of like put on a new hat, which is going to be a very fun thing for me to do, I think, too. I do treat kids in the pelvic health arena for bladder and bowel conditions. So I have some experience with kids, but not with movement type therapies. So as LSVT Big. So it's going to be very, very fun to like transfer my skills and all my years of experience with LSVT Big and people with Parkinson's to some kiddos in my clinic. So yeah, I'm just excited to see where it goes. And I know that we really could use some research in this area. We do have a PT colleague that has a good relationship with LSVT Global in that he has his own private clinic, and he's been doing some care with individuals with neurodevelopmental conditions, and amazing results there with him as being a PT. And then he has an OT colleague there that is working with them as well. Changes in functional abilities with this one little girl being able to put a ponytail in her hair using both hands, and helping to clean the litter box. That was a strong desire. So having very specific goals that are important to those kiddos and being able to make a change in their day-to-day life, having them be able to help around the house and do things for themselves is going to be pretty exciting. I can't wait to see more.
Oh, that's great. That is really exciting. And I know you've jumped into other areas before without, being into it that much yet. So I just feel like you're going to do great in this area. So I'm excited to hear what great things you do there. And I'm going to put in a little plug. You mentioned the therapist, Dusty, who's working with pediatrics. So we do have a webinar we did with Dusty last year. You can find that on our YouTube page or the LSVT Global webinars. And then you can see some videos and hear more about his kind of firsthand experience and perspective on LSVT Big with pediatrics. So definitely check that out if you're interested. And while I have you on here, we'll just do a couple more questions. I'd love to hear, I know you said, your life path kind of shifted when you thought you were going to do physical therapy, and then, you learned more about occupational therapy. So what would you say to kind of like, what advice would you give to people who may be interested in going into the field of occupational therapy?
Yeah, I think that I would say you could really do anything. You could do anything. I like what Julie said. I mean, we treat the whole person. There's so many areas you could specialize in, and you find your passion, you can really go for it. And I think a lot of areas of therapy now or rehabilitation care are specialized a little bit more because there's like so much to know about different areas of practice, and to be able to like really take on your specialty and be that go-to person to treat those individuals, I think is a really cool thing. So I do encourage when I talk to students, like, this is just such a great profession to be in, because you can find your passion and really take occupational therapy anywhere. It's an amazing profession. So that's what I would say.
All right. I love it. Thanks, Erica. And Julia, I'll ask you kind of an advice question here too. What would you say, or what kind of advice would you give to people who are considering LSVT Big as a treatment option for either for Parkinson's or other populations as well?
Oh, I absolutely recommend it. And I always had my students go through it, because I think what LSVT Big does so beautifully, especially for occupational therapists, is, it's getting better, but we don't have this huge body of research evidence, because so much of what we do can't be quantified. It's more qualified. And so for so long, we've had to really go by more theoretical concepts. So change point theory, neuroplasticity, motor learning, like all of these things. And what I love about LSVT is I feel like it takes those kind of abstract concepts and puts them into real world practice. And so I think it really does help guide the concept of how you use amplitude, and not only training it within an exercise. And that's something I think sometimes therapists get a little bit hung up on. I remember one time I was teaching a course, and one of the tasks that they were supposed to work on, like a hierarchy task, was bed mobility. And this OT asked me, well, should we do side planks? And I had the hardest time understanding the question at first until I realized they were trying to make it an exercise. And so what I think LSVT does that's so beautiful is taking those exercises that really apply the amplitude, but then it's the application of that into those person-centered concepts of what daily tasks that individual needs to do. So I think that it really fills in the gaps of how to address neurological conditions, that there really is more of a paradigm shift around that. A lot of times of not, it's very different than treating a knee replacement or a hip replacement. We're really working more on that whole person and not just you fix something and it's better and we're done and moving on. This is really progressive. So it's part of a chapter. So I think that LSVT really arms occupational therapists and physical therapists with knowing how to apply those kind of abstract frameworks and concepts, but then also really drills down to the heart, especially with Parkinson's and with movement disorders, of where those issues lie. Like Erica said, with ataxia or even with dyskinesia and Parkinson's, a lot of times it's more the control. It's really the movement being very clear, very crisp. Where is the start and the stop? With Parkinson's, that's the same thing. But I think looking at what about the movement needs to be addressed is different than what a lot of OTs sometimes want to do, where they feel like we should give a compensatory aid or some type of strategy. It's really looking at how do we address those movement changes. And also what I love is it involves so much of that education piece too. You're not just teaching it to the person or telling them what to do. We're really trying to embed it and calibrate it and help them feel that difference so that hopefully they'll be able to take that and be empowered to move on and move forward and feel how to move differently in their body. So I think it is just such a win-win in so many ways. I can't recommend it. When I had students, all of my students had to be certified in LSVT Big before they started their placement, because I felt it was very important even for them to understand the concepts, not even about the protocol or the 4 times a week, but even just understanding amplitude as a concept and how to apply that.
Yeah, that's great. And I love that idea of that calibration so that they have to feel it, so they know how to do, what you're asking and modeling for them, but also, again, taking it over to other aspects of their life is so important to have that. All right. Well, I won't keep you guys much longer. I'm going to just end with a kind of a parting question for you both. And Julia, I'll go ahead and just start with you. If you have any kind of parting words or anything you would emphasize for OTs who might be in the audience.
Absolutely. It's my perpetual cognitive soapbox. So I didn't end up at the Lewy Body Dementia Association for no reason. The people with Parkinson's with cognitive impairment, and you guys, Lewy Body Dementia includes both Parkinson's disease dementia. So it's estimated that 50 to 80%, the latest data set suggested more like 80% of people, if they live long enough with Parkinson's, will develop dementia. And then dementia with Lewy bodies is similar, but just the cognitive changes happen before the movement changes. So what unfortunately happens in our society is the word dementia equals Alzheimer's, but that's not true. And that's not what it looks like for people with Parkinson's. So that amnestic presentation that we think of with Alzheimer's, where people can't remember their grandchildren's names or where they grew up, we typically don't see that with Parkinson's disease. What you need to know and understand is that it's more executive function deficit, so that planning and organizing, visuospatial issues. So a lot of times trouble mapping and navigating space visually, and then even problems with attention, which of course can impact a lot of domains. But that does not mean that they can't do a program with like LSVT Big. It does not mean they can't improve or get better. And unfortunately, what I hear so much at LBDA is a lot of our very expert clinicians from around the country say, I referred my client to therapy and they went to therapy and the therapist refused to even evaluate them or treat them because they said, if you have Lewy body dementia, you can't make any improvement. So please know out there, if for patients with dementia, if OT doesn't treat them, I don't know who's going to. Like, it really is in our wheelhouse, right? We need to be there for them. Even if it's teaching the care partner how to cue them, how to cue that amplitude, that's better better than the care partner having to physically assist. So please, 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 that's my one last soapbox for the night. Don't give up on people with cognitive deficits. Don't assume that someone with Parkinson's can't learn or can't learn to do big or can't do therapy. It's really not accurate. So that would be my one thing, is please treat those people, because we've been, even since just the webinar we did with LSVT a couple of months ago at LBDA, I've been getting emails from so many families saying, we found an LSVT clinician. My husband or wife is doing so much better. Thank you so much, because they've been refused therapy, or they, gone in and it was just kind of wimpy therapy, I guess, for lack of a better word. They didn't really think that they could drive, to Erica's point, and really push that intensity. So don't give up on people just because they have a cognitive impairment.
I love that. I love that idea of being in their corner. You can do this. We're going to do it, and I'm going to help you get there. So that's amazing. So thank you, Julia. I appreciate those words of wisdom there. And Erica, same question to you. If you have any parting thoughts or points you want to emphasize to any OTs who might be in the audience here today.
I loved what you said, Julia. I've seen so many people that have cognitive impairment that I never give up on, because they can have restoration. That is the big word I love. You said before, Julia, like sometimes OTs think, oh, we just give a sock aid or an adaptive device or compensatory technique or no, I believe we really can restore function. I feel like I use less and less adaptive aids actually with having LSVT big in my corner, because they don't need it. They can actually use, I'm not saying not everybody can go without some compensatory techniques. However, restoration is a huge, huge deal. And we can achieve restoration even in someone with cognitive impairment and these physical impairments that can be restored. And so I love using the term restoration. And as you were talking, Julie, I was like, restoration. I was just saying that in my head, because I just feel like we have the ability to reduce burden on the person, reduce burden on the caregivers by restoring abilities that aren't even thought still could exist or still could be there. My perpetual soapbox, however, is also, I have one of those, Julia, and that is the bladder and the bowel and the pelvic health stuff that I do, and how that sometimes gets ignored, as well as being something that these individuals with Parkinson's have to live with. It's just aging. It's just what you have. You had babies. You know, it's what you have to live with. Well, that is not true at all. As you mentioned before, Julia, these things like anxieties about bathroom use can cause freezing, can cause falls, more motor impairment, and significant reduction in quality of life. It changes the person's ability to want to exercise, to be able to think they can exercise. If you can't go to the gym without needing to go to the bathroom or leaking, or you can't poop every day and it's not comfortable to exercise. So I can change people's lives in that way. And I teach a course that I wrote on pelvic health, or Parkinson's disease and pelvic health. It's a 2-day course for individuals who want and see a passion in that area too, because it can change the person's ability to progress with exercise, because we know exercise is so important in helping with Parkinson's disease. We don't have a cure right now. And so exercise can really take it to the next level. And if the bowel and the bladder aren't working right, we can't exercise well. So I think that would be my soapbox, Beth.
I think it's great. I love that you both, you can tell you both treat your clients as this holistic person as they are. And I think it's really amazing and empowering to see that. And I'm thinking that we couldn't have chosen, better first guests on here than to have people like you two who are brilliant, and you empower your patients, you empower therapists. So I thank you for being our guinea pigs for our first podcast here. I really appreciate you jumping on and sharing all that wisdom. So thank you. I can't thank you enough. I'm so excited for people to get to hear these great words of wisdom that you've shared with us. So thank you for joining us. And I'm going to give just a few shout outs or credits to those who helped make this podcast possible. The theme song that you're hearing is very cool. This is a song called Think Loud for Parkinson's by Kindred Spirit and Leo Sayer. This is a new song and video that were inspired by LSVT Loud speech treatment, and it was developed to raise awareness for Parkinson's worldwide. It is available for purchase on Amazon and iTunes, and the proceeds are split between a UK charity called Cure Parkinson's and the Parkinson's Foundation in the US. So definitely check out that song, spread it, far and wide. I also want to thank our production team who helps make all the behind the scenes possible at CS Design Studios. And for anyone interested in learning more about LSVT Loud or LSVT Big, or to locate therapists in your area, I encourage you to go to our website, lsvtglobal.com, to learn even more. So again, a huge thank you to you, Erica and Julia. I really appreciate your time and wisdom sharing with us today. And I hope that we can have you on another podcast sometime in the future. And for everyone in the audience, we hope that you enjoyed our first episode, and we look forward to thinking big and loud with you again on a future episode.
I speak up 'cause I wanna be heard.